This is a chest radiograph of a middle-aged woman with a known history of omental carcinomatosis who presents with progressive shortness of breath. The frontal radiograph shows an increased distance between the stomach bubble and the left lower lung, measuring more than 2 centimeters, and the right diaphragmatic peak is displaced laterally beyond the midclavicular line. On the lateral projection, the posterior costophrenic sulci are blunted, findings that are in keeping with pleural effusions. The large size of these effusions is better appreciated on bilateral decubitus films, which demonstrate layering of fluid on both sides, and on subsequent CT imaging that confirms large bilateral pleural effusions compressing the lower lobes. These appearances represent bilateral subpulmonic pleural effusions. When pleural fluid collects between the diaphragm and the lower lobe, it is referred to as a subpulmonic effusion. This pattern can be difficult to recognize on an upright chest radiograph. Radiographic signs suggesting a subpulmonic effusion include an increased distance between the stomach bubble and the lower lung of more than 2 centimeters, and lateral displacement of the diaphragmatic peak. Another subtle feature is the loss of visualization of the pulmonary vessels beneath the dome of the diaphragm. On the lateral projection, there is typically blunting of the posterior sulci, a horizontal or flattened contour of the diaphragm, and sometimes a tongue of fluid extending along the major fissure, known as the thorn sign. A subpulmonic effusion can easily mimic an elevated hemidiaphragm or small lung volumes, so awareness of these features is essential. Decubitus films are very useful to confirm the diagnosis, as free pleural fluid will layer along the dependent side. The lateral decubitus view is more sensitive than the upright film and can detect as little as 10 milliliters of fluid, compared to the 175 milliliters usually required to blunt the costophrenic angle on an upright view. In this case, the effusions are bilateral and likely malignant, given the background of peritoneal carcinomatosis, which can cause transdiaphragmatic spread of fluid or pleural seeding. The management of pleural effusions depends on the underlying cause and the patient's symptoms. Large or symptomatic effusions, particularly malignant ones, may require therapeutic drainage for relief of dyspnea. If the effusion is under tension, urgent drainage is required, as it can produce hemodynamic compromise similar to a tension pneumothorax. Empyemas and hemothoraces also require drainage to prevent fibrothorax and trapped lung formation. In summary, this case demonstrates bilateral subpulmonic pleural effusions in a patient with omental carcinomatosis, recognized by the increased stomach-to-lung distance, lateral displacement of the diaphragmatic peak, and blunting of the posterior sulci. This pattern highlights the importance of carefully assessing diaphragmatic contours to avoid missing subtle but clinically significant pleural fluid.